did independent lung ventilation. So what is independent lung ventilation? So independent lung ventilation entails anatomical and physiological separation of the lungs. Anatomical separation encompasses physical isolation of one lung from the other. Physiological separation refers to ventilating the two lungs independently as single units. So a little bit of history of it. It was first used in 1931 for thoracic surgery by Gale and Waters. It was done by passing a single lumen tube into main bronchus into the good lung. So in 1936, McGill used endobronchial placement of a suction catheter with a balloon to occlude the operative bronchus and catheter and tracheal placement of an ET tube to ventilate the good lung. In 1947, Moody covered the endobronchial balloon with metal studs to reduce the risk of balloon dislodgement, which, yeah, sounds terrible. So in 1949, Carlines used the first double lumen tube, allowing independent lung ventilation of both lungs. This tube had a hook to engage the carina to be placed accurately. Although it was an improvement of the tube, it caused trauma and was not usable for a left pneumoectomy. In 1960, White used the first right dual lumen tube that did not block off the right upper lobe bronchus. So then in 1962, Robert Shaw used right and left dual lumen tubes, which served as the prototype of today's DLTs. So present DLTs have replaced red rubber with polyvinyl chloride, so PVC, to reduce mucosal injury and improve, I'm going to stutter over this word, malleability and airflow. In 1976, Glass and True and their co-workers reported independent lung ventilation for non-surgical purposes such as respiratory insufficiency from unilateral lung disease. So institutions and specializing conditions frequently requiring ILV, such as single lung transplantation or alveolar proteinolysis and other lung issues. So, what is the purpose of this therapy? So, the anatomical separation is typically used for circumstances which require lung isolation to prevent cross-contamination of the healthy lung by harmful material confined within the diseased lung. Physiological separation of lung is used for refractory respiratory failure resulting from unilateral disease, producing marked differences in pulmonary mechanics between right and left lung. So in the presence of a non-compliant diseased lung, conventional positive pressure ventilation would result in significant overdistension of the non-diseased lung and can potentially cause volume trauma to the non-diseased lung. So overdistension of the non-diseased lung could result in change of pulmonary blood flow to the diseased lung, thus worsening the shunt and hypoxemia. By doing an independent lung ventilation strategy for each lung may prevent volume trauma to the non-diseased lung, reduce shunting, and allow for alveolar recruitment in the diseased lung. So some of the indications in doing this procedure is if you have massive hemoptysis, pneumonia, aspiration, single lung transplantation, bronchopleural fistula, lung contusion, if you have copious infected secretions in one lung, so like a lung abscess, and you don't want that to get dropped over into the good lung. Unilateral pulmonary edema, and then there's also thoracoabdominal aortic repair, lung reduction, pneumonectomy, and thoracoscopic procedures. So I couldn't find any contraindications, so I'm just going to tell you a little bit about the complications. So a lot of these complications are most specifically with the DLTs, because the pressure generated by the bronchial cuffs. So the PVC tube cuffs can generate pressures of over 50 millimeters of mercury with an inflation of just 2 milliliters. So it's not that much. This is the estimated inflation required to generate a functional seal. And when I mean not that much, I mean not that much air required to reach that high pressure. So with that happening, it can cause bronchial ischemia, stenosis, and end up causing a pneumomediastinum, and subcutaneous emphysema have been reported as subsequent complications. So deflating the cuff when moving the patient can reduce the risks. So risk factors increasing the likelihood of bronchial rupture, traumatic intubation, cuff overdistension, oversized dual lumen tubes, prolonged intubation, and patient-related risk factors for bronchial trauma are underlying malignancy, infection, chronic steroid use, and prior tracheobronchial surgery. All right, so for this slide, physiology, there's different types of tubes that can be used. So there's an endobronchial tube, there's dual lumen tubes, there's an endobronchial blockers, and then I'll explain what the bronchoscope is for. So the single lumen endobronchial tubes, which are longer than normal endobronchial tubes, but with smaller external diameters and smaller cuffs. So it's inserted into a particular mainstem bronchus to ventilate that lung, so causing spontaneous absorption collapse of the other lung. So they're not commonly used, and if they are used, it's more so on children. It lessens the chance of the cuff from obstructing the upper lobe bronchus. So the other one, the DLTs, are the most common. They have left and right mainstem tubes. The more common tube that tends to be used is the left-sided DLT. It can be used to ventilate both sides of the lungs. They're pretty much two tubes of unequal length. They're separated at the proximal end to initiate independent lung ventilation on two different circuits, or connected by a Y piece to the same circuit. So another method for facilitating lung isolation involves blockade of the bronchus to allow lung collapse distal to the occlusion using devices known as endobronchial blockers. So this is better explained in the video I have on the next slide. And also the bronchoscope is used in place to help place the tubes. So they'll go down, visualize where the carina is. That way they can make sure they're not in the wrong mainstem, or they're not too far down, or they're not too high. So the bronchoscope is used to help with the placement. So here's just a video of basically showing how the tubes are placed and how they basically work. So if you guys want to take a look at that, it explains a lot better than I would. So it's kind of a slow, annoying video, but I feel like it has good information. Alright, so what are some of the parameters that are controlled in this therapy? There's one way to do it. This is done by using two different vents. By doing so, we can control the tidal volume, the PEEP, the respiratory rate, and the FiO2. So while using the two vents, they are cabled together to create synchrony. With this, you want to use the same FiO2 on both vents. The patients need to be heavily sedated and paralyzed. Also, and then there's another method that you can use, which is asynchrony. So this is done in tandem. So the tidal volume, the flow, the PEEP, and the FiO2 are all independent. And then you have one vent that controls the rate for both vents. Alright, so vent settings. So you want to set the tidal volume no more than half of the estimated tidal volume. So one of the resources I read stated that it is controversial on which mode works better for this type of situation. So not sure, maybe it depends on what is trying to be achieved with the settings. So one of the facilities that I read about, they use bi-level mode is used, PEEP and FiO2 being selected according to the ARDSNet/Berlin ARDS definition recommendation. While plateau is maintained below 30 centimeters of water pressure, and respiratory rate is set to optimize CO2 removal while maintaining a pH greater than 7.10. Usually, respiratory rate is kept below 28 breaths per minute, with inspiration to expiration ratio, so I to E, less than 1:1. The tidal volume in uninjured lungs should be kept within 3 to 4 mils per kg of ideal body weight, while in the injured lung, tidal volume is initially set to 2 mils per kg per ideal body weight, and then titrated accordingly, not to exceed a plateau of 30 centimeters of water pressure. The respiratory rate in the diseased lung is set to 10 breaths per minute, and an IDE is set to greater than 2:1. Working pressure plateau, so PEEP, to so the working pressure, so plateau minus PEEP, to less than 15 centimeters of water pressure. So that was just at one facility. I think it just depends on what facility you're at, what kind of protocol they have for it. But there's an example of one of the facilities. I don't know what facility it is, but it's pretty interesting. So why this mode over conventional ventilation? So this can be used to as a lung protection technique. If you need higher PEEP in one lung, this mode allows for each lung to be delivered gas independently, and then lung transplants, etc. So if you're trying to ventilate both lungs and one is stiff and hard to ventilate, the gas will take the path of least resistance and can over-distend the healthy lung, like I mentioned earlier. So if one lung is requiring more PEEP, this may be a better solution than just adding regular PEEP when helping with oxygenation. So when receiving a lung transplant and the good lung needs to be ventilated, or we're trying to repair a lung, so this type of mechanical ventilation is mostly used in surgeries that I've seen so far. Alright, so making adjustments for ventilation and oxygenation. So first you want to assess the position of the tube, and when doing this, try to use a bronchoscope. Otherwise, you're just doing it blindly, and you could possibly move the tube too far in, too far out. Just roll it over to the wrong lung. So you also want to try to clear the airway of mucus secretions or blood in the ventilated lung. So you can increase PEEP up to 10 centimeters of water to the ventilated lung. So higher PEEPs can cause diversion of blood from ventilated to non-ventilated, increasing the shunt and worsening hypoxemia. So 10 centimeters of PEEP improves the FRC of dependent lung. So increase of FiO2 if lesser is being used to 100% now. So CPAP, or high frequency oscillation, or high frequency jet ventilation, to non-ventilated. This is acceptable only in open thoracotomies and not in VATS and thoracoscopic lung resections, as this inflation of lung interferes with vision of surgery and is usually discouraged. So intermittent lung recruitment maneuvers can be used on operated side of lung. So suction catheter connected to the auxiliary O2 port can be inserted in lumen of non-ventilated lung airway. This prevents hypoxia without inflating the lung. So optimization of hemoglobin levels and cardiac output. So if a pneumonectomy is planned, early clamping of pulmonary artery of non-ventilated lung eliminates the entire shunt, thus alleviating the hypoxia. So at times, an intermittent double lung ventilation technique may have to be resorted to if nothing else works, basically. So that is my last slide. I hope you guys learned some new information. I know I did. It's pretty interesting to see how it works and how it's done. So enjoy. And also don't mind my babbling. I tried to record this like 50 times and I'm still stumbling over my words. So this is as good as it gets. All right, so making adjustments for ventilation and oxygenation.